Good morning, everybody. Hope everybody's feeling rested. We're going to get started today, all right? So I'm here to introduce Dr. Tammy Ritzma. She is an associate professor at George Washington University and St. George's, the University of London PA program. She is an active health workforce researcher with a specific focus on the development of the PA program, the PA profession outside of the United States. She also conducts workforce research on the deployment of PAs in emergency medicine within the US. Dr. Ritzma is a regular speaker at national and international PA conferences, and she is super excited to be here with us to speak to all of her Canadian colleagues. Please welcome her.
Good morning. I wish I had a lavalier mic because I'm a wanderer, but there isn't one for this room. I also apologize for my mask. I take pretty substantial immunosuppression, so I'm under orders not to take it off. So thanks for understanding that as fellow PAs. I am fully aware that probably 75% of you wanted to learn about bone marrow transplants this morning, and you were robbed of that opportunity, so you're here with me. This is actually a research talk, but I'm going to try to give it a bit more of a clinical spin, considering the audience. So first of all, who here works in emergency medicine? Okay, we got a bunch. And then who here works in primary care? A lot more. Excellent. Okay, and then do we have any like internal medicine hospitalist types? Outstanding. Okay, so actually, this talk is actually really relevant to you guys. Okay, if a 55-year-old man comes in with chest pain, not terrible chest pain, not dying in front of you, right? But they come to primary care or they come to the emergency department. What's your differential before you even look at the patient or the chart? So yell it out. So ACS, I heard ACS. Okay, what else? PE, especially in the age of COVID, right? What else? Oh, sorry, everybody said something at once and I couldn't hear it. GERD, absolutely. What else? Musculoskeletal chest pain, right? Sorry? Anxiety, excellent. Yeah. So we have things from the very pedestrian, right? I strained my chest wall, helping my son lift the sofa into his new apartment, to I ate too many hot dogs, right? To like my life expectancy is 2 to 3 hours because I'm infarcting my heart, right? Abdominal pain, a 23-year-old woman comes to you and complains of lower abdominal pain. What's your differential? Pregnancy, PID, ectopic, torsion, appendicitis, UTI. Yeah, Crohn's, UC, right? Just, went to Mexico and had Montezuma's revenge, right? Like a million different things. And again, right? They range from not so serious to potentially life-threatening, right? And so that actually is one of the impetuses for the study. I don't know if you'd say impetuses for the study that me and my colleagues ran. Okay. So this is the formal emergency physician and advanced practice provider, which is the extremely annoying American way of saying PAs and NPs. I didn't make it up. I have to live with it. It's horrible. Okay. Diagnostic testing and admissions decisions in chest pain and abdominal pain. I did this with Jesse Pines, Mark Zoki, John Bedolla, and Arun Venkat. We published this in Academic Emergency Medicine. I should have fixed the citation because now it's past 2021 and it in fact has been published. So in the United States, health services research has traditionally been done on billing data. So when you see the patient, you mark down all these different things you did and you ask the insurance company to pay you for them. The way that PAs bill for their services in the United States doesn't show up in a lot of these data sets, because it turns out if the doc even sort of walks in the room and waves at the patient in the emergency department, you can bill it under the doctor's name, and that gets you 15% more reimbursement. So almost everyone tries to have the doctor, at least we call it a drive-by. Glad you're feeling better, Mrs. Jones. I see Tammy sorted you all out. Have a nice day, right? I can bill 15% more if somebody does that, okay? So that means then that it doesn't get billed under me. It gets billed under the doctor I worked with. So it looks like I worked a whole shift and didn't see a single patient, okay? So we have had a very hard time showing the value of PAs to the health system, okay? A few published papers with very, very dubious methods have asserted that PAs and nurse practitioners compensate for their shorter duration of training by ordering more tests. In other words, I don't know what it is. I can't take a good history because apparently we're not very smart, is apparently the thinking. And so I can't differentiate between a left-sided ectopic pregnancy and a cholecystitis. And so I'm just going to order every test in the book. Now, one of these studies actually literally compared all PAs, and they did it completely wrong, but all PAs to just family doctors, and said, surprise, PAs order more x-rays. They included ortho PAs, emerge PAs. I'm a neurology PA as well as an emergency medicine PA. All neurology, like neurology without MRI, are you kidding me? Right? We're hopeless. So they actually presented this at a large national meeting, and one of my PA colleagues had to, like, I'm a city girl, had to prevent me from go beating them up. Because I really thought about it. She literally grabbed onto the back of my coat. So we wanted to do this. We wanted to answer this question in a more sophisticated and methodologically sound way. It turns out, right, so their argument is, people say, well, PAs and NPs can save health systems, and not just the US health system, but health systems around the world, money. That benefit would go away if PAs and NPs are ordering way more tests, right? That would not be cost saving, okay? So we actually looked for a non-insurance-based data source. And what we're seeing now is that big data and statistical and coding methods that allow us to go through this data fairly efficiently, they're new. And I think actually this is a very big opportunity for like a provincial health system. Denmark does this amazingly well. All the good studies are from Denmark. My students laugh at me because I'm always presenting data from Denmark. And I'm like, I've never even been to Denmark. They just have really cool data. So within the US, that's much harder to find. So actually, I partnered with US Acute Care Solution, which is a large emergency medicine practice. They have more than 200 emergency departments in 19 states, and they have everything from rural hospitals to the University of Pittsburgh Medical Center, which is a very large level 1 trauma emergency department. And they have an ongoing team that does this work already. And the US Physician Assistant Education Association actually funded us to do this research. I have to thank them for their money every time I give one of these talks. Okay, so what we actually did was looked at the billing data, because that is still collected, and we married it with their clinical database. Obviously, it's all de-identified, right? But we could identify everything about the patient, plus everything about every provider that saw them. So we could see if they were seen only by a PA, only by a doc, by a PA and a doc, by a nurse practitioner and a doc, all that. We brought 13 million emergency department visits over a 4-year period together. And this is an existing database, so we did not need ethics review. Okay. So the reason that we chose to look at chest pain and abdominal pain is exactly where I started this talk, right? If we did this for ankle fracture, it wouldn't be that meaningful because the differential diagnosis is tiny, right? And it's not usually a life threat. Where the rubber really hits the road is when you have a potentially benign or a potentially life-threatening chief complaint. That's where you would get into potentially over-ordering or under-ordering tests. And so that's why we use this. We also use them because they're incredibly common. And so we knew we could get a large data set. Okay. So for chest pain, we looked at what labs were ordered, whether an ECG was ordered, any kind of imaging. So chest x-ray, CT, CTPA, right? If people are thinking about pulmonary emboli, and then admissions stratified by age group. Okay, I want to know from the Emerge PAs here. Do you guys have this saying in Canada? So in America, we say your chance of being admitted to the hospital is your age. So if you're 101, you're coming in. I don't care if you have a paper cut. I mean, that's exaggeration, right? But we know this, right? Because our risk stratification systems tell us that people who are older are more likely to have serious consequences or might be less likely to be able to care for themselves in the home environment. For abdominal pain measures, we looked at the labs again, whether or not an ECG was ordered, right? Because sometimes abdominal pain, especially epigastric pain, can be either cardiac in origin or cardiac in origin, and then imaging, right, including ultrasound, CT, and x-rays, and then again admissions stratified by age and sex, right, because gender is a confounder in abdominal pain. Okay, so we basically just did some what are called descriptive statistics. That's like percentages and counts and things. And then we used inferential statistics. That's the more fancy statistical methods that you think of that allow us statistically to control for some things so that we can make meaningful comparisons. Okay, we looked at admitted patients and discharged patients separately because we feel like that's actually two pretty different populations. And then very, very few patients had missing data. I don't know if anybody's a statistician here, but we did a Bonferroni correction, which is a way of making sure that you don't over attribute statistically significant results. Okay, that is super blinding. I don't expect you to be able to read it. It's painful. Okay, but I will just point a few things out. So there was about 900, almost 1 million chest pain visits. There was about 650,000 abdominal pain visits. So again, we feel like this is really representative data. Okay, and we looked at some of the patient demographics. Some of the things that are really important from the slide. First of all, abdominal pain is on the left and chest pain is on the right, just to orient yourself. And then PAs and NPs within each are on the left and docs are on the right, okay? The important things to look at are basically severity. So very down at the bottom, a smaller number, an ESI level of 2 is a sicker patient than an ESI level of 4, okay? We didn't look at ESI level of 1 because those patients are actively dying. So we didn't feel like that was a very hard thing. Like somebody comes in with a STEMI, there's no decision. You get them to a cath lab, whether you have to fly them to a cath lab or whether you have a cath lab in your own house. Okay, so what we found is that doctors take care of the sicker patients much more than PAs and NPs. And that could be because PAs and NPs in some of these places might be working like in a fast track or urgent care. There may be rules. There's 200 EDs, but they all have different rules. So when I worked at Johns Hopkins, I was allowed to see everybody. At the emergency department I work at now, I was allowed to see everybody, but that is not the case in every ER. And doctors also take care of older patients. And again, older patients and sicker patients, there's a big overlap in the Venn diagram there. Okay. On this slide, doctors took care of patients with more comorbidities. So you can see hypertension, diabetes, cancer, COPD, congestive heart failure, asthma, renal failure. In all cases, the doctors took care of higher percentage of patients with comorbidities. And again, this may be because, in part, because PAs and NPs in some of these places are limited to seeing fast track patients. Okay. Okay, don't get scared. This is a crazy statistical technique called inverse propensity weighting. I don't even actually know how to do it. I know what it means. I don't know how to program it myself. So you definitely don't need to know. On the left-hand side is the unadjusted, this is just counts. What percentage of people got X versus Y, okay? And actually, if there's a dotted line down the center, and to the left is physician patients, and to the right are PA patients. So actually, you know, when you first look at that, you think, wow, you know, the doctors are the ones that are over ordering the tests, not the PAs and NPs. But again, we can't just do simplistic analysis. We have to control for those things that I told you about, right? The sicker patients, the older patients, okay? And so when you do that, that's the middle column. And since the horizontal bars cross that dotted line, it means there's no meaningful difference, okay? This is chest pain. When you looked at discharged patients only, you see that actually doctors order more CTs. And actually, I think this has an interesting potential interpretation, which is it may be that doctors are more confident in discharging patients after they've considered a PE or a dissection or things like that. Whereas maybe PAs and NPs are a little bit more likely to say, I just want to have that person observed overnight. We can't tell that from here. That's just our guess. But there's certainly no category in which PAs and NPs over-ordered tests relative to doctors. Okay, here's the abdominal pain. We have the exact same thing, the unadjusted, which really is kind of meaningless on the left. We have all visits in the center, and here doctors were more likely to order an ECG for abdominal pain. Again, this may be a function of severity of illness that they're seeing the level 2 patients. PAs were more likely to order a beta HCG. That we still don't know what that means. I don't know if anyone does anyone have a hypothesis about that? Honestly, yeah. Yeah, that's a really interesting thought, Corona, right? We do know, at least in the US, PAs are definitely more female than docs. Do they think of it more? Again, is it they're seeing people in like an urgent care? I don't know. We couldn't explain that one. And then we saw pretty much the same results with the discharge only patients. So again, no gross over ordering on behalf. It's not like, they come in for an appendicitis and the PAs are ordering a lipase, right? And a head CT, right? They're not ordering crazy stuff. Okay. So what we found overall was that PAs and NPs see more lower acuity and docs see more higher acuity. The unadjusted analyses showed PAs using fewer resources, but when we controlled for severity, and all the other things we controlled for, those findings mostly disappeared. So PA and NP practice did not differ from MD practice when the controllers were put in the model. Again, emerge PAs. Does this make sense to you? Does this resonate with your experience? It certainly resonates with mine, right? I sit in the emergency department. I sit next to the doc. The nurse says, I'm putting a 60-year-old male chest pain in room 3. And before I even walk into the room, I've usually clicked ECG, chest X-ray, troponin, CBC, metabolic panel. And then I'm going to go in the room and I'm going to talk to them and I'm going to think about a D-dimer, right? Now, I might come out and cancel that if it's chest pain. One of the rural hospitals I work in is horse country. So chest pain kicked by a horse, not uncommon. And let me tell you, for this city girl, that was a whole new world. I seriously didn't know that horses and cows kick, but apparently like a lot. I'll tell you, actually, I saw a woman got thrown off a horse and she walked into the emergency department and she had 4 lumbar vertebral burst fractures. And when the radiologist called me, I'm like, oh God, she's paralyzed. I'm going to go into that room. I'm like, do not move. The helicopter is coming. Horses are really dangerous. Okay. Discussion. So again, previous studies asserted that PAs and nurse practitioners use more resources to come to diagnostic decisions. But they are very, very badly conducted studies. We used a national level data set incorporating a wide variety of emergency department types, which for the first time captures the direct contribution. All these other studies were not using proper data, okay? What we can't tell you is if the patients were seen in the fast track or the main emergency department, that might influence it. And also there's one kind of difference between PAs and nurse practitioners in this group compared to all other emerge PAs in the US, which is this group actually has a fairly rigorous and dedicated training program that new PAs and nurse practitioners go under. Plus, all their health professionals, docs, everybody continuously engages in certain kind of quality assurance activities related to high acuity patient care scenarios. So that's not common. I can speak to that as an emergency medicine PA for 18 years. That's not common in the United States. And so that might limit the generalizability of this data a little bit. The other thing is, and some of you may be aware of, there's discussion in the United States about PAs pushing for essentially independence. This data does not really support that. We could see that this data could potentially be misused. None of these PAs worked without a doctor on site. They may work very autonomously, but there's always a doctor on site. So it's not indicative of how people would practice if there were no doctors. So, it'd be great to do this kind of research more in primary care and hospitalist medicine. And again, we're really hopeful that sort of the big data that comes out through government health systems, through private health systems, and even in the United States, there's one dominant electronic medical record provider, and there may be some opportunities to aggregate data there. Again, I want to say thanks to the PAEA who funded it, and to thank you guys for inviting me to speak. I will just say, I'm doing fine on time. I will just say, I'm giving one more talk later on today, and probably people might be gone, but that is about what happens when you're the very first PA working in a hospital in the UK. What made that go well and what made that go badly? And I think that there's a lot of potential application in the Canadian system, right? As you guys expand, thinking about how to set things up from the beginning in a way that might facilitate the smooth integration of that PA into a hospital. So just a tiny advert for my next talk. Questions? Yes. So PAs and NPs were much more likely to take care of younger patients. Age group, here you are. It's right in the middle. So if you look at the U in results and go over, you can see in all cases, like the 55 plus saw 28%, doctors saw, had 28% of their patients over 55, and PAs and NPs had 17% of the patients they saw. And again, in chest pain, 46% of the chest pain patients that the doctor saw were over 55, whereas only 30% of the PAs patients were over. Yeah, absolutely. That could be. That could be, although we did control for age in the model statistically. Yeah, you and then you.
So I guess it's first off, more of a comment than we went to your question, but I was on the side of things. And when it comes to ordering tests, they're just a bit for something. Sometimes patients are there for weeks and then the doctor will pick out see blood cracking and to see that you're okay. And even things like that, I wonder, is that even helpful? So I feel like on the ED side of things, sometimes it's very critical for decision making up on the spot.
Right.
Inpatient side of things, sometimes is this relevant or not? It's very interesting reading it like inpatient data.
Massively interested in, yeah, that was kind of what I was talking about at the end. I can't do it with this data set because this data set is owned by an emergency medicine practice. But there are increasingly large numbers of larger inpatient providers of inpatient services in the US. And that is something we're actually very, very interested in doing. You have to apply a lot of pretty rigorous statistical controls. Because as you know, there are people that get admitted with congestive heart failure, and some of them are just literally drowning, and others just need a little, they need a little diuresis, and they're going to go home. And so you have to have measures, from a data perspective that allow you to control for that. But that's exactly, and that's, you guys, I'm trying to get you guys to think yourself, right, about your environments, because I actually think that that provincial level health systems have some potential capacity for this as they increasingly network their their EMRs together. So yeah. Uh-huh. Yep. Yep. Yes.
Our order set, for example, was automatically through the last page or after the page.
Mm-hmm. Right.
Myself, but it just becomes they get a triage.
Right. Yeah.
So I'm wondering, like, if that was a factor in that set, and you guys are able to control that.
Yeah. So we were not. That's a great question. Yes, that's a great question. And that question, that issue would underestimate a potential difference, right, between doctors and PAs. So yeah, that is absolutely a limitation to our study. The order was attributed to the person who ended up taking care of the patient. Okay, so I'm going to pick on this gentleman in the front here. If he's the doc and I'm the PA and you're the triage nurse and you click on chest pain panel and he ended up seeing them, or I ended up seeing it, would be attributed to him or to me. But we know that protocols save lives, right? Like, I don't know if people have read Atul Gawan's The Checklist Manifesto, things like that, right? We know this helps, but it does make it harder to do this kind of work. And I think that's actually where you see things like the ECG and abdominal pain, right? That's one that would clearly not generally be part of an abdominal pain panel. It's interesting to me again, and that the beta HCG in the abdominal pain came out different because, at least in my institution, the beta HCG is hardwired into the abdominal pain panel. Like, it reads what is the age and gender of the patient and puts it in or doesn't put it in based on that.
send them to our class.
Oh, wow. Okay.
So I just wondered.
Yeah. Right. Yeah. Yeah. Yeah, I think those are really good questions. And just out of curiosity, does a attending or a consultant have to sign the ECG for that determination?
Yeah.
Okay, because I was gonna say, to be honest, I love emergency nurses, love them, but I would not personally be that comfortable with a triage nurse making a determination on an ECG, particularly on a patient with a lot of risk factors. Yeah. Uh-huh. Okay. Yeah. 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 So that doesn't happen in the US simply because Americans are so darn litigious. And 50% in emergency medicine in the US, 50% of all lawsuits against an emergency practitioner are for a chest pain related thing. So if you think of every other thing that can go wrong in the ED, all of them together equal just chest pain. So people in the States are very, very, very freaked about chest pain. So, yeah.
Sounds like that you directly that you're comparing, all of abdominal pain to this to each other.
Yes.
But of course, like you said, abdominal pain presents very different.
Mm-hmm.
So it's that to of a study, but to look at like two comparable patients, right? That a 25 to 30-year-old female who comes in, sees an PA, sees a doctor, they have the same prevention complaint, and from there, what that's sort of.
Yeah, so you can't, but I want to make it clear, this is actually an apples to apples comparison on a population level, right? Because the question is not comparing people based on their final diagnosis, because that's easy, right? The thing that makes emergency medicine challenging is this patient walks in and now I have this world of diagnoses in front of me. And what decisions am I going to make that if I make the wrong decisions might cost somebody their lives? And so when we do the statistical controls, that turns them into basically comparable populations. And because we had almost 1 million chest pain visits and 650,000, we have what's called the statistical power to make those comparisons valid. It would be, you wouldn't gain any statistical power with a one person to one person approach. Right. And very, very powerfully. Yep. All right. Thank you for taking the time. I hope to see a few of you later to hear about British PAs who were the first people at their hospital. Thanks.